If you're on the phone, please holler.
Josh said he's
Josh is here.
Holler.
Holla.
I heard it beep.
What's his
Quiet
name?
on the set.
I can't tell who's.
Josh is still here.
All right. And then just holler when you drop off too, so we know that you at least.
So we can talk about
We
it.
gotta talk about you when it's
Don't do it on the toilet.
You're on there already. I think he's good.
All right, here we go.
Madame.
So lots of cases. We're going to continue that literature review. We ran through it last time pretty fast. If we have time, we'll go through it again. Helmet removal, which we skipped last time, and then Versed. One of the best medicines in pre-hospital care. All right, here's first case, 23 pneumo that's being transferred to Methodist. There's nothing really spectacular about this. We're not going to go through the case in profound detail. But we're just transporting a lady with cystic fibrosis down to Methodist, where a pulmonologist is. And this is her x-ray. So here's the pneumo down here. So anytime you can see the pneumo going all the way down, that's not small. If it's just up here, that's kind of small. You can maybe wait on it. This person's like 90% going to need a chest tube. And then you compare that to tension over here. So heart's kind of pushed over to the right, great vessel's kind of pushed over to the right. You can see the kind of bifurcation over here, the bronchi. So that's what cuts off your blood supply when you get a tension pneumothorax. We only bring this up really because what do we do if a patient decompensates? Do we intubate? Do we needle decompress? What size needle? Where do we put it? There's actually a lot of controversy in this stuff right here. Typically we're here, second intercostal space, midclavicular line. A lot of mistakes is if we go too medial. A lot of research done in this area, and nobody knows the right thing, but ACLS is now going to be, or ATLS, to be recommending 4th and 5th anterior line for placement. That's ATLS. Doesn't mean we recommend it. I don't know what we recommend. I think either one's fine. But there's a lot of ifs and ands and buts and what to do about it. Just know there's two places, and you should know both. But if you look at kind of failed, I can't read it from here. So second intercostal space up here fails 38% of the time, and then 4th and 5th anterior fails only 13%. And so there's some animal studies, and there's some combat studies, all showing that this 4th, 5th intercostal space, anterior clavicular line, so, or anterior axillary line, sorry, right about in here, is actually the best place to go. Consider using it in that space. Now, Schwartz is a big dude, so, you know, you're going to put a lot of needle through here, and most of the people in Indiana are also big people, so that's the whole point. What size needle do we have? How long?
2.75 per inch, I believe.
So we need probably 5s if we're doing it here on fat people.
We have the, what's it called, Scott?
I knew you were going to ask.
Is there a like a pre-filled like something or another?
Yeah, it's not a turtle needle, but he'll get you one.
And are they on every truck?
Yeah.
So in this picture, if you're going to do it here, and we'll talk about this maybe in detail, like in some sort of procedure lab or whatnot. So if their arm's out, this is the anterior line. Go to nipple. You really can't find Schwartz's nipple, but this is actually pretty low. Most people are going to be kind of up in this area, almost just inferior to the armpit, where you're going to stick this thing. And you want to go towards the chest and not, you know, so it's almost perpendicular to the ground, in like that. And that's going to miss a lot of vital structures. And this goes for peds too. Peds, most of like if you're going to go here, and if you're thinking as a trauma on a kid, their thymus lives here. It's huge when they're a kid, and their heart can also be up against the chest wall. So they're also advocating for that. I can't open this thing.
Yeah, it's broken.
Oh yeah.
Jesus, look at the sworn on that.
So it's got is there a sheath on it normally?
No, the idea behind it is this is spring-loaded here. So as you're pushing through, that retracts. The needle does the cutting. And then once you puncture
That's
the
the
pleural
needle?
space, yeah,
There's no cutting needle there. Oh, there it is.
yeah.
That's it. It's in there, okay.
Can we get a Band-Aid?
We probably have to use a new one. There's HIV on this one. So anyway, these are all kind of new concepts, just stuff to think about when we start doing skills labs and whatnot. I don't know how often you guys do skills lab, and I would like to be invited. But that's kind of where I think most people need to go, is this side. So start thinking about it. And if you can't get it here, it's really fine either space, but consider both. It's a pretty rare indication. Most traumas, most gunshot wounds are really not tension pneumothoraces, but if your patient's crashing and there's nothing left to do, then, you know, it's at least a temporizing measure. Questions with that? That's kind of a big deal. We'll kind of go over this again. Kind of, there's a lot of research coming out. All right, here's chest pain. This is a 50-year-old guy, chest pain, respond lights and sirens, holding his chest. It's non-radiating about 40 minutes prior to arrival. He's able to speak in full sentence, and we noticed ST elevation in lead 3, given aspirin, and a repeat EKG and noted some increased change in 2-3 AVF, so we ended up calling it a STEMI. Nothing really incidental or too concerning. Blood pressures are good. SATs are good. We noticed sinus rhythm on the first, maybe lead 3, and then we call it like, I don't know, 15 minutes later. And we'll just go over EKGs. This is our initial one. Can we call it on that? This is lead 3. I think that's what we're seeing. And we talked a little bit about AVL a couple times. Whenever you see AVL down, especially in inferior changes, that's really, really likely to be a STEMI. So keep that in mind. And then you got these, I call them check mark sign. You just kind of, the ST segment starts right from the QRS. Not a lot of space. That is also concerning. That's just, it's almost pre-elevation. So whenever you see these kind of check marks, AVL, and you got some concern, you can pretty much call it. Here's the progression. Our first one. Then we get something that does this, and you can tell, again, how big the T wave is compared to the QRS now. So there's dynamic changes. This didn't really elevate, but now you have kind of deeper inversions here. So dynamic. So if you see 1 to 2, you can say, hey, that's, you leave the leads in the same spot. You know there's something dynamic going on, so you can call that. And then this is the third one in the ER. Again, kind of remains elevated, starting to get there. And this starts to calm down. So kind of a bizarre dynamic changes to the EKGs. Pretty cool. This is classic. These check marks in this AVL, I mean, that's enough. So you can call it right there. Something good to remember when you're looking at these. So this guy had an 80% LED, so it's probably coming and going. Thrombus was there, probably 100%, and going down to 80, 100%, so that's why you see these changes. And he had an EF 40, 45. So ends up being anterior, even though he had inferior changes. There's anytime you see this start to elevate in the anterior leads, it's a big MI, and I would put pads on, because those are the ones that most likely have tachyarrhythmias. So most of the inferior stuff, if they're by themselves, are pretty not arrhythmic, but anytime you see an anterior changes, just put the pads on. Hello?
Hello?
On?
Yep.
Okay.
Welcome.
Okay. Hey.
Hi. All right, and this is another STEMI that we ran on a 60-year-old at a golf course, and he was on the pale diaphoretic, complaining of chest pains for an hour and a half before calling 911 in the clubhouse, and we note STEMI pretty much right away on his first EKGs. There's those anterior changes. V1, V2.
I mean, it's ugly.
Pretty nasty. I would put pads on this guy. He's going to go into arrhythmia. It's like 40% or something crazy. So get ready when you see those. And the one thing about this guy, why he waited an hour and a half, he's probably had a really good round and he just wanted to die in the course. That's what I would want.
Yeah, might as well die then.
Might as well die.
Oh, we sponsored that event, by the way.
What's that?
We sponsored that.
Did you really?
Yeah.
Were we already there?
Yeah.
Ready to go?
We had a lot of fried food.
Yeah.
It was a community golf outing, so,
Oh, yeah.
Oh, really?
yeah.
I'm glad we showed up to help out. Maybe get some publicity. Here's his prior EKG, ours that we ran on, so big changes there. And then this is his in the ED. So,
Oh, yeah.
kind of bigger ST stuff here. Not a whole lot of changes, but starts to have his reciprocal depressions. And then this is happened in the cath lab, and shortly after. It does some weird, I can't tell, it's a probably ventricular, fast ventricular rate, but I don't know. There's no P waves and it's wide. So something weird happened just after the cath lab. Malala never talked about it in his note, but I mean, he got an EKG for that. So they're arrhythmogenic, be careful. So anything anterior, just put the pads on. All right, 78-year-old liver cancer, weak chest pain, syncope, and tachycardia. We're called for possible heart attack. This guy, I don't know if it's a guy or a gal. I think it's a gal. Super sick. No, it's a male. Sitting in his chair. He's conscious and talking. And he's obviously does not appear well. He's weak. He had a syncopal episode, but while he was in the bathroom, he struck his head. And he said he had chest pain prior to the event. So called 911. Complains of weakness and headache from the fall. Skin is cool, pale, cyanotic, and we couldn't find a pulse. We noticed VTAC pretty much early on, and we're able to get VTAC confirmed on a EKG. We called in for orders, got ambio ordered, and he is currently receiving chemo for his liver cancer. So not a guy that's very well at baseline. Blood pressure's still difficult to obtain. He's got a thready pulse and he's talking to us. And he converted once we arrived just with ambio. So VTAC, guy who's talking to us with a lot of medical issues. Don't see these every day. Here's our EKG. Okay. This one's not subtle, but they can be. You know, can you tell if it's a bundle branch block, all that. 90% of the time this is VTAC, so don't waste your time thinking too hard about it, but there are some ways to do that. Stable versus unstable, who really knows? I use mental status as a primary condition because then you can just shock them if they're on decreased mental status, so you don't really have to sedate them. So if their mental status goes down, they start becoming just shock. You know, that's easy. It's this guy that's talking with thready pulse, and you can't really tell what his blood pressure is. I mean, is he stable or unstable? Splitting hairs, no real yes, no to that. Well, what I will say is, what is the cardioversion rate with ambio? What do you expect? What rate do you think you're going to convert this guy from VTAC? Any guesses? Doesn't matter if you're right or wrong. I had to look it up. What's that? 30. 30, that's a pretty good guess. 40. So you get a 40% chance of getting this guy out of, hey, he guessed though, at least he guessed. And then what about electricity? Well, what's the rate to getting out of somebody with electricity?
60, Flucker.
What's that?
60.
60?
Yeah.
No, that's a little higher, so 90. So I don't know, if you're playing the odds, somebody shock me if I'm in VTAC. What's the biggest thing missing from this chart? And I have to go back to look at it, and it's probably done, it's just not listed anywhere in here or here. We should have him on defib pad. I'm assuming he had him on, but
We
just
did before we even left
good.
the house.
So it wasn't listed. Put him on the pads, because get ready, because if he starts going down, you just push the button. Shaka Khan.
Really?
What is the max rate? We have Zols, is that right? So what's the max on that? 200?
250.
250? That's their max recommended rate?
I think that's in that, I think on the biphasic.
Biphasic? What? I thought it was 200? 200? 200.
I thought it was 200.
I think it's 200.
200.
Is that?
I know 360s is the old monophasic, and I thought 200 was all.
Yeah,
Most
it goes
of
up
the
to
recent
200.
stuff.
It'll deliver more than that, but that's why you can set it up to is 200.
200, yeah. Don't ever do anything besides 200 in an adult. Everybody's doing these big. I don't know if it's just listed when you gotta shock people, but it's like always come down at like 120 or 150. Just if we're shocking somebody, give them the whole dose. I don't care what it's for. This is prior.
That's an angry heart.
That's not heavy. No. So you can tell, this is just for learning purposes, that, you know, this guy normally does have a bundle branch, blocky looking thing, but here it kind of, so if you happen to have an old EKG, you can tell that V1 is obviously opposite his, look to be a left bundle branch block, but now he's got right bundle and V1. So you can use V1 to kind of tell which type of bundle branch block you're in. If you turn the EKG to the right, and V1 points to the right, that's a right bundle. If it's to the left, it's a left bundle. That's how I do it. And so V1 will tell you, this is a right bundle branch morphology, and he normally would be in some sort of left bundle. So it's opposite, so he's most likely in VTAC. If we're going to be really picky about it, you can sometimes tell what's what. In the 20 minutes we're with the patient, it's VTAC 90% of the time. So unless you're running on a child who most of the time have these kind of fast, wide rates, they're almost always VTAC. So don't think too hard about it, but there are some ways to help to differentiate the two. Our protocol is ambio and then lidocaine, which is reasonable, but know that all these drugs really don't have a lot of research behind them. I think procainamide is now starting to come around as one of the better ones to use, and maybe we'll get a hold of that one. So we'll see. But ambio is kind of the poster child for almost all EMS. So it worked in this case. Here's how you can somewhat tell the difference. Remember, capture beats, infusion beats, these are there with VTAC. They look like sinus beats, and we'll go over those, or in-between beats, but when you see them, that actually more likely is going to be VTAC. And then the bunny ears and we'll go over this in a better slide, but the bunny ears on a bundle branch block usually go up, down, and the right one is taller, so a right bundle does this, so that right one is taller. So if you ever see the left bunny ear taller, that's most likely VTAC and a wide rhythm. This is just an algorithm to go down. If you have basically an RS, so QRS, this is RS, so just up, kind of like ours here. So just up in all leads, that's VTAC 100% of the time. So real quick, you can just look at it, up, up, up. Now you got an RS right here. See how it goes back down, and you got one right here. So you can't use that rule, but if they're all up, that's VTAC. And that's kind of a quick and dirty way to look. And then if the R to S interval is greater than 100, then you can also call it VTAC. So that's another one you can use. So start of the R wave, and this is any precordial lead. Let me find it. So it's right here. R to the bottom of the S. That's like 4 blocks, right? So that's greater than 100, 40, 80, 120. So it's 40 per box. So you can tell that's VTAC by looking at it. There's VTAC in a lot of ways, but just if you had just that one, you could tell. And that's what that means, the RDS ratio. If you see AB dissociation, which is really, really hard, so you see P waves, little upbeats, and they're not corresponding, then you know that's VTAC because they're not talking to each other, and your heart rate's 280. And then this one is really beyond the scope of my knowledge. I'm never going to remember it, but it's here somewhere. We'll go over it. So here's your AV dissociation. Here's your P waves. They're not talking to each other. These are really hard to see with fast rhythms. Capture beat. So that is the true kind of a quick sinus beat that kind of goes through because your sinus node's going off and just getting interrupted by the VTAC. So if you see these or these kind of fusion beats that look kind of halfway, there's another capture beat. That's more likely VTAC. So that's confusing to me. I'm sure it's confusing to other people. If you start to see that in the midst of a bunch of runs of wide rhythm, that's VTAC. So you don't have to think any longer. You're done. And this is that last rhythm. And it really doesn't matter. The bottom line is if it doesn't look like a bundle branch block of V1, V6, here's your RSR prime, the top bunny ear for a right bundle. If it doesn't look like that or that for a right bundle or that and that for a left bundle in V1, V6, then it's most likely VTAC. But you can go through this later on once you've got home and decided if the patient's dead or alive. But, it's never really going to be helpful for us. So we went kind of over why this is VTAC. It's not quite all RS, but it's pretty close. That QRS, that first 100 milliseconds for R to S is greater than 100. So, and then I can't see AV dissociation. Maybe these little ditzels or P waves. I don't know. But good to go over every once in a while. VTAC comes around, shock it. You can give amio and talking and walking people, but whenever you're in doubt, you always got electricity. I would like Versed first if you're going to shock me, but or you can just kind of let me go unconscious. Either way is good. Versed is a wonder drug. We'll talk about it. 60-year-old with decreased level of consciousness and vomiting, airway compromise. We have a few airway issues this month. This is an intercept from Central Village Community, and going from a BLS to ALS. Female patient supine, vomit coming from her mouth. You never want to hear that. Attempting to suction, agonal respirations, and was having a hard time waking her up. Put on the monitor, signed Brady in the 50s. We were able to place, I think the first IO was...
First IO we put in, we
couldn't get
top unscrewed.
Yeah, that was
Get the
weird.
needle out.
That's weird. Just a defective IO or something weird. Yeah, so we got a second one in. Running out of places to put them, but good to get it in. And then we were unable to intubate because couldn't see the cords. Suction. And then start to go into CPR mode. Initial attempts to intubate, unable to see cords, large amount of vomit. So attempt to suction, multiple times. And this becomes an issue. This person's pretty sick too. Asthma, cirrhosis, hypertension, hypothyroidism, osteodiabetes. So always tough when you got a person who's alive that goes dead. Makes you feel like you could have done something more, and most likely you can. But difficult intubation, and you missed it. Don't. But that's part of this job. But what could we do? And we'll talk about it. So intubated, even in the ERs first in the ride was difficult for Dr. McAllister, but he eventually got it in. pH is 7.1, CO2 105 by the time got there. Stabilized and admitted in AT hospital course and never had improvement of her mental status. So she was brain dead. So what can we do? We can intubate, no duh. That's what I used it. I don't know. It's a good term. We should use it wrong. You can leave it in the esophagus. And most people, once you put it in the esophagus, you just leave it there. Put it in the left corner of the mouth, and if puke's going to come out, it comes out that hole. I tend to pull it out too, like most people, but if it's in the esophagus and you're certain of it, just leave it there. That way, next time you put your ET tube in, you might get better luck if it's just bouncing off the other tube and going north. Especially when you can't see when there's a ton of vomit. Do we have 2 suction catheters on a truck most of the time? Do they
Suction, portable and
portable on a wall. So use 2, and then use the Yonkar on 1. So just as more of a hose, and the Yonkar get where you need it, hose where you need it, and then a supraglottic. Still function pretty well. I know the King Airways also tend to act like a faucet because they go right into the goose and all the fluid comes out the top. But still can oxygenate. Our goal is to oxygenate. So if we're having a hard time, it's been mucking around the airway for minutes, then you got to oxygenate or they're going to decompensate. So think about a supraglottic early. Digital intubation. Anybody attempted a digital intubation? My fingers are too super small. I can never get it done.
I got big hands,
So I don't know, but something to think about. Really just get your non-dominant hand in there. You feel the epiglottis, and you try to slide the tube right underneath the finger. You can use a bougie for this. Might be a little easier. And then you can just put a whole bunch of bougies in there. Just keep placing one after the other till you hopefully hit some sort of ring structure. And I've done this and gotten lucky. So if you have a whole box of bougies, just start going at it because you can't see anything.
Come in looking like a plant.
Yeah, whatever. Just leave it in there, dude. Just keep going. Eventually, there's going to be no room in that esophagus anymore, and you'll get it in the right spot. I mean, this is the next one's cut the deck, and I don't know how many people are comfortable with that. So, I love bougies. I think they should be done with most intubations, if not everyone, to get used to how to use them. So. Difficult. A lot of our airways are difficult because we're stuck in austere environments and weird back of the trucks and big fat people that aren't properly, perfectly oriented on a bed, and you're standing right behind them. So, you know, use the bougie. It's your friend. Here's an unresponsive parking lot. This is a unconscious younger gentleman, 37, who bystander called at 3 in the morning for somebody acting weird. So has trauma to his orbital regions and face. He's unconscious but responsive. Has a patent airway with equal chest rise. Respirations for 16. We placed a C collar on. I don't think there was like an obvious MVA or anything. We just found this guy unconscious in a parking lot, probably fell down. He's now alert oriented. He starts to get combative. He's got a strong odor of alcohol, and we reveal kind of an intact head on exam, bleeding from his nose and airway, and no blood from his ears. His pupil is reactive to light, but the right is dilated, so that's a little bit concerning. We're able to get IV access. He's still combative, so we just RSI'd him, give him etomidate, sucks. And unable to visualize cores, becomes bradycardic, given atropine, intubation attempted again, and could not visualize cores, placed a king. Entitled at that point starts to pop up in the 50s, and we got air ambulance to help move this guy home. So it kind of sounds like a drunk dude that fell over that we RSI'd kind of early, but I don't know. Anybody here with this guy?
Yeah, I was here. So we got called for reports of battery.
Okay.
By a passerby. Initially he was unconscious. Get him in the truck. He wakes up. Can't remember the event. He's just being an asshole at this point. So we RSI'd him. Tried to get in there and look. And as soon as we got in there, he bradied down. Tried again, and just really interior.
Okay. Did we RSI him because he was a dick?
No.
That's not a good indication.
No.
So there's another miss. Seems like we jumped the gun. I don't know. I'm not there. I can never tell you. But describe it better while you're intubating, because it sounds like the guy was alert and oriented, and then we just said, "Hey, we're going to tube you." So get down exactly why. Always airway protection is a good one. Say that there's secretions, whatever. But good use of supraglottic, and quickly, because we tried twice. More than 2 times starts to get worrisome. So it's not a sign of failure that if you can't intubate. I like the Kings. I'm more partial to the iGels. If anybody have those around, I think they're just anytime you can not mess with a balloon seems easier. But Kings are easy to place and seem to be very well tolerated, and get oxygenated well with them. So I'm not against them. But, way to go early to the supraglottic. I don't know what happened to the guy. I couldn't tell where he went. I couldn't find. I had sent the 86 people a couple notes, and they never got back to me. I think it was one. This guy was one of them.
I guess he's out. He picked up his belongings, so.
Yeah, good. Yep, hopefully he's okay. All right, unconscious and vomiting, which is a theme. It's the vomiting. This is a 21-year-old unconscious and vomiting blood. That's our dispatch. And we got another crew there. It's got AED and have a faint carotid pulse. Reassessed. There's no obvious blood in it. We think it's something red. She probably drank some scissor up or some red cough drink. But was given nasal Narcan intranasally first. And we noticed pinpoint pupils, so we kind of go down the pathway for overdose. In the back of the ambulance, patient's ventilations were assisted with bag valve, which doing well. We noticed the CO2 to be 43. Placed a nasal trumpet and started oxygenating, and then just continued to bash her with Narcan. So total of 2 milligrams of Narcan were given. IV, and she finally dilates her pupils and starts vomiting wildly. We had to roll her over. And she finally admits at that point that she took Xanax, but wouldn't admit that she took any opiates. And we were able to remove her NP airway kind of en route. So a good case to, not all the time does your first Narcan work. doesn't happen again, try again, especially with those pupils. So way to be aggressive with Narcan. In this case, she stayed a couple days, probably aspirated, but never needed anything. And then her story changed from alcohol only to Xanax, and then she also went to heroin. So truth comes out 2 days later. Way not to believe people. 67, trouble breathing. This is a female who's, we have NED treatments running. She's renal failure, GERD, heart failure, hypertension, and depression. So again, a super healthy lady, and she's got unresponsive and foam coming from her mouth. You got the things coming out of the mouth, theme still going on. So faint pulse, quickly goes to VFib and changed to asystole. So don't really even give time to shock her. Started compressions, secured an airway with a 7-2, and noticed end tidal at 26, and started coming down the asystole pathway. We got a bump in her end tidal up to 85, and noticed a sinus brady in the 40s, and we were able to kind of get her right over to the bed. Of course, every time someone transfers barely alive to an ER bed, it's a death sentence. As soon as they hit that bed, they die every time. So we lost pulses right when they switched over. Never were able to get her back. But this is a renal failure patient, so perhaps we could have treated hyperkalemia. Really had no way to know. Didn't have an EKG to show it. Ours was VFib and VTAC, or VFib, and then a slow bradyrhythm. But know that hyperkalemia will produce any rhythm. It's not just peak T waves. That's the first sign that's going to happen. Then it just goes into all sorts of badness. So VFib, PA, wide brady, and asystole. All these are possible with hyperkalemia. So if you know the renal failure, it's okay to just treat it. Really what we're down to is bicarb, nebs, and calcium kind of coming in. We have calcium on the truck? Gluconate or? Yeah.
Yes.
So yeah, I mean, if you have time with the patient, and you know, these are really not a lot of downsides. So even if you're wrong, it's not a big deal. So if you see someone with a fistula and they're coding, or you know that they're kind of pending renal failure, go ahead and try those things. Those are the ones that will get them out of the rhythm better than anything else. Unconscious on the porch. This is a 23-year-old on his porch, unresponsive, GCS of 3. It's already, it sounds like an overdose, but has a carotid pulse. If he was in his mom's basement, it would be 100%. His breathing is 5 times a minute. His friend reports that he took an unknown amount of Xanax. So we started ventilating, and we noticed sinus rhythm, placed in 18, and currently small amount of movement, GCS of 6, and made a decision RSI based on his GCS. We were able to pass that to 22 with the lip and tidal 38. So, and we pre-sedated with 20 milligrams of etomidate. I don't know if that was an extra etomidate, maybe, kind of prior to coming in, which is a good sedating medicine, but only lasts, 5 or 6 minutes. So you have to keep giving it. Here's our strip that we have. So how can we calculate heart rate on something like this? Is just a review. Especially if they're really bradycardic. This one has nice lines. I don't know. These 2 lines are actually exactly the half a minute time. So you can just multiply this by 2. 1, 2, 3, 4, 5, or multiply 10. 1, 2, 3, 4, 5, 6, 7. So that's 70. I don't know. Usually it's 6 of these boxes. 1, 2, 3, 4, 5, 6. Or this one kind of already had it set for you. So you can always just multiply by 10. Same thing here. So about 2.5, so about 20 times a minute on his breathing. So probably over breathing a little bit down here. So this was kind of an OD. We didn't even try Narcan. He didn't believe the last person, but we believe this one that it was only Xanax. So I think we're picking easy targets to get candy on this one. But he DC'd the next day. There was concern that his antibars were laced with fentanyl. This was that was actually a quote from his discharge. So, but tube's in the right place. That's good. And Larson, I love lady, and paramedic student. Is there a paramedic student? We'll give it to anybody.
Oh,
No.
he used to be, but now he's just an EMT.
Bill Larson? Oh, were you here?
He's on the phone there.
He's on the phone. I'll take his candy for him,
Can I, is there a,
since that last tube that I got.
Yeah, I'm here.
Josh, do you have anybody you trust here to take the candy for you?
I trust Love to take it.
Wow. All right.
Wow, you fool.
I did not hit the coffee. I did not hit
Ain't
the.
on there now.
And next time, give them Narcan, candy loving fool. What's that?
If he eats it, he'll lose his foot.
All right, looking out for your buddy. I like it. All
But he
right.
won't have to work with you anymore, he said then.
All right. There's a 62-year-old seizure who stopped breathing. We have a lot of not breathing people this month.
Then we heard.
Yeah, let's see here. Get my bearings. So we arrived. The spouse says, "Hurry up! This person's not breathing." And this patient just left the hospital from St. B's, has a PICC line and something else removed, and she's seizures and was incontinent bowel and has a irregular pulse at 50. So we put her on the truck and placed pads and noticed idioventricular rhythm at 42. And we decided to intubate. 22, good foggy end tidal reading, positive end tidal reading. I don't know what that positive reading was, it wasn't listed. But went immediately into VFib and shocked at 120. Did we really shock at 120? No. It's always 200, 200 for anybody that's an adult. And she ended up coding, so no candy because she didn't ever get a chest x-ray, she died. Shoot. So, that's, gotta get this documented, put the number in there, make sure you check it more than once, because this means you did not intubate the person, or at least we didn't document it correctly. So make sure you get that down. That should be in there somewhere in the chart that we have a good waveform. Fogging the tube will not be enough to get some oil off your back. So make sure you document a couple rounds of end tidal. Could have been in the goose. All adults get maxed defib, so 200. All right, we got another status, this one with brain cancer. Do brain cancer patients with seizures stop? Not usually. So usually if there's something going on in that brain cancer area, they have a real hard time stopping seizures. So if you have a known seizure or a brain cancer patient prepared for a prolonged seizure, this is one of them. 66-year-old focal seizure. So they tend to be focal at first, and then they go more general. And this one is said it's been there for 45 minutes. So patient's husband sat there and watched her seize for 45 minutes and decided, hey, this is enough, and called us. So tachypnic, snoring, respirations, pupils start to dilate, non-responsive, head elevation. We just kind of get everything ready to set up. Glucose is 129. We got started with Ativan, 1 milligram, and then 5 milligrams of Versed without any change. We were able to get an IV, which is awesome in someone who's shaking around. And start the bagging. Ventilated with just bag, and we get end tidal with that. It's 94 with 15 liters. So it's not good because they're going to drop like a rock. But we decide anyway to go for suction and etomidate. And for success, unsuccessful due to unvisualization of the cords, we put a king in. Secured it 8 to 20. Well, no, we secured it with a king vision, not a king tube. And then kind of rolling down the road, we still have our 30 to 45, so we had to put in 2 different numbers. And still reading 44 on the way, and then given etomidate and Versed again for sedation. I think she got another 5 milligrams of Versed. This one went to St. B's, must have been closer to St. B. Started to get a lot of resistance with bagging. Maybe first thing is to decompress the stomach when you've already done bagging and you're trying to having trouble bagging somebody who you're pretty sure has an airway, and decompress the stomach. And here we got a whole bunch of end titles shows that we're positive, so we're in the right place. And we got 17.5 milligrams of Versed and 2 of Ativan, so that's a good aggressive benzo protocol right there. most idiopathic epilepsy, these are your people that have seizures all the time, will stop on their own. These ones that are more focal and from lesions tend to last longer. If it's more than a few minutes, or when by the time you got there, they're still seizing, it tends to be harder. So seizures, we get more seizures. So being aggressive with benzos is the way to go. So even with children, and their doses are much higher than we give adults. It's 0.1 per kilo. So like a 10 kilo kid's getting a milligram of Ativan, where we're just giving a milligram of Ativan to the adults. And they get better doses, but they chew through it faster. So every 5 minutes or faster, we should be giving benzos, and a lot of them to people that are still seizing. So we should be well versed in Versed. Actually, these are spelled the same way. First cost is 35 cents, so we can't break the bank with Versed. So it's good for all these things. Most of them really were going to be as anticonvulsant, maybe an anxiolytic, potentially pain, status, alcohol withdrawal, and procedural sedation. So that's what we see it for. When you compare it to others, it's one of the short acting. And it's only lasting a couple hours. Most people kind of start to get out of their Versed treatment within an hour. So that's pretty fast when you compare it to Ativan, which is a half-life of 10 to 20 hours. This is a half-life of 2 to 3, depending on your liver enzymes. Valium, it's way up there, like 30 to 100 based on metabolites. So Valium long-acting, Ativan kind of in the middle, Versed short. So we like that short to help us reevaluate the patient, make sure their airway is coming back to normal. The downsides of that is they may seize again. So you have to redose or just consider using another benzo after their seizure stops. So most of the time we're not going to be holding on to these people too long. But long transport or something, you're transporting a seizure patient downtown, and you have to stop them with Versed, maybe giving them Ativan as well for the transport is a good idea. So Versed is one of the only water-soluble benzos, so it can give you any way you want possible. This is why it's such a good drug. You don't have to have an IV, and we'll go over that in a second. You can give it per rectum if you're inclined. You can just put it in the cheek. Intranasal is also a good route, and it has a short duration of action, as we talked about. Some variable metabolism based on that this is metabolized in the liver. So alcoholics tend to have their liver enzymes kind of hypermetabolizing, and so they'll chew through this kind of fast, but you can always give more. And side effects, we kind of know these. Rarely do we see bronchospasm, laryngospasm. I think that's probably from someone vomiting and then kind of choking on their own vomit. I don't think it actually causes this stuff. But amnesia is huge and probably a good thing. They won't remember us taking them in. They can't write our name down. And hypotension. So they do get hypotensive. So if you got an old grandma that you're giving benzos to and Versed to, suspect that you're going to be hypotensive in a little bit. It's just like fentanyl in that respect. So start giving fluids. Some respiratory depression, but not even close to opiates. You can give 15 milligrams of Versed. They tend to continue to breathe. That's the only thing that's on board. Pre-hospital, here's a New England Journal of Medicine study in 2012. It's IM versus IV therapy for status. And this is IV Ativan versus IM Versed. They're equal. So you don't even have to wait for the IV. This was a study based in the pre-hospital, and it said by the time you decide you're giving it, you open it up and you give it. You can give IM faster without an IV, and it works just as fast as the IV route. So you don't even need the IV. So if you're stuck and you got this big lady or small kid, just give it IM. It works the same. This water solubility of it makes it just kind of go into the tissues, into the circulation really fast. So you don't have to wait for the IV. It's better to have, but if you can even kind of preemptively give it while you're looking for an IV. And then excited delirium. There's a prospective study by this New Bay, and they studied Versed versus Haldol versus Ativan, maybe a little underdosed on the Haldol, but it was faster to sedate the person and shorter acting. So when we think about ketamine as kind of the go-to in a lot of arenas, and we're mad that we don't have it, but Versed works really good. So I've seen people give as much as 10 per dose. think ours is 5, so 5, and then you can wait another 5 minutes, give another 5. That's gonna get people sedated most of the time. So in these agitated delirium folks, I would start with benzos first. Unless there's psychotic folks, and you know they've got a psych history, then antipsychotics may be a little bit more beneficial. But to your standard crazy drug addict, you know, Versed is a pretty good choice. And then ped seizures. It's good for ped seizures. And again, give it any route, intranasal route, IM route. You don't have to have that IV. It's not on Brazil, so know the dose. It's the same as Ativan, 0.1 per kilo. But Ativan has a max of 2, Versed has a max of 5. And you just gotta know this dose, and you gotta kind of commit it to memory. Because in the heat of the moment, you're either gonna look it up. I don't know, this is kind of how I would do it. You have a 1 ml syringe, it's gonna be 5 milligrams in this whole thing. Each one of these is gonna, the whole thing's gonna be 5. So, you know, half of it's gonna be 2.5. Typically, for a 15 kilo crate, that's gonna be 1.5 milligrams. So 0.5, 0.5, 0.5, 0.3 mils. 0.3 mils is magically kind of the best fluid for nares. So once you get above 0.5, it starts not to work. You can do max 1 mil per nair, which would be 5 milligrams, but usually in these kids, you're going to be giving less. And so if you have some kid that you're giving intranasal, just split the dose in half and give it one side and then the other side. It works really well in ped seizures, and the folks downtown routinely give this to almost all their ped seizures. So intranasal is a good route. Think of it early for kids. All right, 21-year-old. That's another intercept regarding an MBA. We found intercept a lady already placed in a cervical collar. She was the restrained passenger traveling at a highway speed, and they were passing a semi. She was the passenger. The driver was passing a semi, and then they struck another car head-on. And the driver of the vehicle was dead on the scene. She's alert and oriented and denies a loss of consciousness. She complains of neck and back pains, leaning towards the left, and states that she can't sit up because she's in too much discomfort. She denies any numbness or tingling of arms, legs. She does have some pain to her left arm, difficulty breathing and abdominal pain, and we noticed some left-sided abdominal tenderness and bruising. So we called for helicopter, just kind of sounds like basis of the mechanism and her abdominal pain. But her vital signs are good, and she got the transfer to St. V's. I did get her report back, and basically she was discharged from the ED, so not sure why the driver got so badly injured. She admitted to doing some sort of meth at the time, so they probably weren't doing standard good living and ended up injuring themselves. But she got discharged from the ER, so kind of surprised to see that. I think this is a difficult call, and just the fact that somebody died with a head-on collision, sometimes mechanism trumps what you see in front of you. So I'm not against that call. It's a difficult one. You don't want to spend your golden hour in community trauma, bleeding to death. All right, here's a head lack and weakness. This is a medical fall, elderly sitting on the kitchen floor, copious amounts of blood on the floor. And the patient's daughter says she was standing behind, holding a cloth over the top of her head. She was walking to the kitchen, tripped and fell, and struck her head on the corner of the counter. So fell forward, and top of the head hit the counter. She complains of head, neck pain, C-collar was placed. She's diabetic, her blood sugar is 270. Continues to complain of weakness and numbness to both arms, and begins to ask repetitive questions. So we got an intercept to kind of help us as she's getting a little more head injured. She complains of bilateral arm drift. Possible causes of weakness and arm drift in an 86-year-old with a head injury. Here's the ones I came up with. Now, if anybody could tell me which ones they actually were by number, you get candy. So you gotta pick them, and you gotta pick them all. So you get to only pick 3. Write them down. Well, we can't do this really fairly because you have to write them down on a piece of paper. So, but it ended up being old, weak, vasovagal, and she had a cervical spine injury. So, She didn't bleed too much. Her hemoglobin was okay. She never really dropped her blood pressure. She never got hypoglycemic. She never had a seizure. She didn't have hyperorgasmia, which is weird in an 86-year-old. But so here's her cervical spine fracture right there. This is C2. And you got that dens coming up, and right through the base of the dens on the lateral view. You can't really see it real good. It's right there. So here's your types of fractures with the dens fractures or the odontoid fractures. It could be type 1. This is our type 2 down here, right at the base, or it can go through the whole vertebral body. 60% of the time is what we see. This probably had some cord kind of stinger, why she had bilateral numbness. A lot of times they'll get central cord syndrome, they can't extend their wrists. So if you ever run around somebody and they're like, I just can't extend my wrists, my neck hurts. It's most likely a central cord syndrome. You get contusion in the central part of the cord. Really variable on how you treat these. It depends on their age and how well their bone is and what the surgeon decides that day. But actually type 3 is better. These heal up really better. So type 2s can require surgery and type 1s are usually non-surgical. So kind of different. It doesn't follow the typical 3 is worse than 1. So. Interesting case. She ended up going to St. V's after being treated in the ER, had a pulsatile bleed from her head, that had to tie off a vessel to get it to stop, and then she went to St. V's and went 2 days later just in a collar. So she'll need spine follow-up. She'll probably fall again before then and mess up her neck. We'll see her again, I'm sure. All right, well, we have a lot of cases. Another agonal respiration from an ECF. And this lady, I think it's a lady, so we arrived, there's no shock advised, agonal respirations, downtime approximately 10 minutes, placed on Lucas, started bagging, and started giving epi, tried to intubate with King Vision, and there's a lot of swelling of the airway, but we're able to intubate with direct vocalization, waveform of 22, immediately goes into V-fib, able to shock pretty quickly, and we noticed absent breath sounds and clear sounds over the epigastrium, but the cuff was deflated because it was just really hard to bag. End tunnel waveform starts going down. Try to re-intubate, and again removed after meeting a lot of resistance, so we just started bagging instead. It sounds like a real difficult airway. Can the King Vision just confirm the tube? Because this is my question ahead. It's more of a camera, right? I mean, if you have a tube which you think is in there and you have the King Vision, can you just put it back in there and see the cords?
Oh, yeah, you can see the cord.
It may be a good idea in something like this where you're having a hard time bagging your initial 20s, just to put the scope back in there before you pull it and see if you're in the cords, because this lady is obviously difficult. So I do that a lot with the glide scope, even after intubating, put it back in there and look. Even become difficult to bag doesn't always mean it's in the wrong spot. So maybe we intubated the first time, maybe not. So it's really, really difficult to know. Think about in an arrest situation supraglottic, because all literature says intubation really doesn't save lives in arrest situations. Supraglottic is just as good. So if you run out of time, just put a supraglottic in and don't think about it. But if you're going to intubate and you already think you're in there, you might want to just check with the King Vision. If you think it can look that well, it's just another option that instead of yanking it. This is what you're dealing with. That's her picture that came up. So she's not an easy intubation either way. Remember, this is what your waveform looks almost all the time when you first intubate, and maybe it starts migrating out. You're going to lose an end tidal after 4 or 5 breaths. So that initial one doesn't count. If it counts, nice to see. But that could just be all the air you just put in the stomach coming back out. So you got to watch the end tidal for the first minute or so and get 6 breaths in before you decide that that is really in. People forget about that. Here's our waveform. It's really really, really small. And this is basically a systole, really, really fine defib. So this lady was not going to do well either way, but hate to see another missed airway. We're dealing with some difficult ones. All right, 71-year-old hypotension fall and wheezing. This one was recent. It was yesterday, I think. So we call on a fall, and when we get there, notice that he's pale, diaphoretic, hypotensive, and has a weak pulse and wheezing. No known obvious allergic component or something that he got into, no stings, no obvious foods, but started down that pathway. It was given Benadryl epi, Medrol, and we're able to confirm signs for them on EKG. His end titles are good, and I was informed later that this actually epi was given IV by accident, so we gave the IM dose IV, and in this case, nothing particularly worrisome happened. The guy actually didn't need any more drugs throughout his stay in the emergency room. So his pressure remained stable. Maybe that's what he needed, was just a good IV bolus of epinephrine. But remember, epi, it's one of the most confused drugs in all medicine and how to dose it. So be careful when you're drawing it up. The little vial almost always goes IM unless you're mixing it up. We don't have these. Most people don't. This is 2 that we carry in the truck. It's 0.01 per kilo, or 1 mils per kilo. And then you need a small syringe, so you're really only going to pull up 0.3 most of the time. And you're going to give that almost always IM. If you're in cardiac collapse, and this guy was pretty close, and his pressure's in the 80s, you can't push this just straight through an IV. You just want to go at like 0.5 mils over 1 to 5 minutes. So slow push. You can also kind of make your own little epi drip or own little epi syringe and just kind of dispel all of this stuff down to 1 mil and kind of get 9 mils of saline back in here, and you have 100 mics just in there that you can give over 1 to 3 minutes. So either way is okay. If you're just giving these little teeny doses like through here, you're gonna have to flush, because a lot of that will be in the actual tubing or in the IV. So push a little bit and flush, push a little bit and flush, and you're gonna give micro boluses of epi. So not another bad way to go. But then you're gonna be using crash cart epi, not this stuff. This stuff is really small amounts, so you're gonna only have 0.3 of a mil. You push that IV, a lot of it's gonna be again in the tubing. So it's not all gonna reach this circulation. You gotta remember what kind of size syringe you have. 1 mil is gonna be normally what you're gonna use to pull that out. So anything you're gonna be using here is gonna be all in this little junket, or even in here, it's harder gonna be to dose it. You can do a dirty epi drip. I've done this a few times. It's pretty simple. I don't even go this far. You put the whole crash cart epi in the bag. So if you've given multiple doses of epi and you've got a long transport, you can just dump all this in there, shake it up, and just open the IV. And then you can kind of titrate it just by your thumb. So if it starts getting hypotensive, just drag it down. You're going to be in a decent range. Unless this thing is pouring in through an 18, like dumping in, you're going to get really a decent range. So the hard part is if it's really dripping in slow, and then you're going to have not enough. So you need a bigger IV. So even if you gave the whole liter in half an hour, it's still like 20, 30 mics per minute. So it's not that bad, and it's a good way to temporize somebody if you don't want to keep giving micro doses. So homework for go home and kind of figure out, or on your next shift or here today, just pull out all the stuff you need for epi and Versed, figure out what syringes you have, and do it for mostly kids, because those are where we screw it up the most, and adults, because the IM and the intranasal routes for Versed are going to be a little different, something we don't always use, and it just takes 10 minutes or so. You've got to refresh your memory every 3 to 6 months, you'll be good to go. We missed a lot of airways. I don't know if we do airway training formally. I like to be there, be fun, kind of try to figure out how we can make this better. We should do this together and come up with a way to to maximize our airways and get a little bit better. One thing I would say is bougie. It's really limited downside. I started using it with all my innovations just for fun and to waste the $3 of the bougie cost. That way when you're ready, when it's difficult, you have it. This is kind of where we left off with last month. We're going to breeze through this really fast. Manual versus mechanical CPR. I'm going to go through this. There's lots of studies. Basically, manual was better. So mechanical CPR is not giving you any benefit in this CARES registry, which is a huge registry of 80,000 individuals from multiple states. So if you're hospital discharge, this survival to hospital discharge is greater in people receiving regular CPR than manual, or kind of what the hell is this thing? Mechanical CPR. So just do manual CPR unless, you know, you just have a long transport. It's okay to put it on there, especially if you only got a few people. There's benefits to it, but the thing is you just don't want to stop compressions. It does take time to set up. Maybe start with manual CPR, and if you get ROS, then it's time to place that thing on the chest for transport. So good for long transports. It's good for rearrests, limited resources. Good for air transport and a bridge to ECMO and PCI. So it's got its uses, but I don't think it's there for prime time in every arrest based on it, and kind of manual CPR being a little bit better. Despite all this, it may be the best thing to help people because of this heads-up CPR that's being instituted in some programs. I don't think it's ready for prime time. It's really just a couple programs. This Korean doctor, I noticed that in high-rise buildings, they were taking people out in Korea. They had these little teeny elevators, and they had to cram these people in the elevator like this. And then they were getting good rates of ROS back. So this Keith Lurie guy, who's a prominent cardiac arrest researcher and the inventor of Rescue Pod, which kind of clouds everything, noticed, you know, that, hey, maybe we should do heads-up CPR. And it does make a little bit of sense if you think of, you know, if you're flat, you're just pushing blood both ways, and it's not really moving anywhere, but if you've got your head up, and you're pushing it up, and it comes back down, kind of maybe some circulation, I guess. So, I mean, there's some theoretical uses to it. There were some pig studies that noticed some increased cerebral blood flow.
They did at the police?
Huh?
I'm being smart.
They were, yeah, I got you. I can't really comment. It's being recorded. So, you know, it's not, I'm not ready to try to find some way to do this to people, but you have to have this to make this work. So there's a lot of research going through now to see if this is any good. I bet you it will fall through like most of these fun new things in medicine, but it may be beneficial down the line. Important note that this guy recommends that you have to use a rescue pod during heads-up CPR. Because he's the inventor. I mean, it's very discombobulated, and that's why I think in the end you're going to have someone else research it. There's a lot of research underway. We'll see. But if you hear people talking about it, that's what they're talking about. I don't think you're ready to stand people on their toes, but it might work. All right, helmet removal. Who's had to do this ever in their career? Oh, a couple times. So I have never done it. I was confused, so I had to do some research. And actually, if someone comes in the ER with this problem, I would just kind of like look around and ask somebody else because I wouldn't know what to do. But now at least I have some idea. A lot of people will recommend to just leave the helmet on. It depends on who you talk to. So like the NCAA says just leave it on and transfer them out. And some of the other societies say, you know what, just take it off. It really depends on who's there at the scene to help you. If it's a football game and you have a bunch of people there that know what they're doing, and then it makes sense to take it off. The thing with a helmet, if you're going to go for motorcycle helmet, there's nothing, you don't have actual pads on, so you want to get that off so that their head and neck is neutral, because they don't have any like pads elevating their shoulders. When you have pads elevating their shoulders, you take the helmet off, their head falls down. So you potentially could have a problem there. You either have to pad the neck with towels and put on a seat collar, or take them all off. So you have to decide with the team, the trailer, and the trainers there whether the helmet or pads are to be removed. You do both or none. You can always remove the face mask first. They're either clips here. You can take this metal mask off. You can use garden shears. There's a couple actual devices you can use for it. Hopefully the trainers have it. Or some of them are just screwdriver to remove the mask. You can always just remove the mask and leave everything on. If you have little choice, if this person's unconscious, not breathing, I really don't think you have a choice but to take it off so you can get to their airway. I think the theoretical potential cervical spine injury is trumped by the immediate airway. So if you have to take it off, you just kind of slide it off. You have to, you have to take you can take the face mask off if you have time. You have to take just undo the chin strap. You want to get your hands way up underneath, kind of by the ears, and then have somebody pull off. These are a little harder to get off than motorcycle helmets. They have pads that are stuck in here. Sometimes you can jimmy the pads off the side. Everybody that's done it, was it difficult?
We just went through new training with athletic directors and Fort Wayne Sports Medicine, and they recommend getting the pads and everything off of them
At the scene.
before you move them.
Yeah, I think that's reasonable. There's a video, if we want to watch the video, to kind of what these folks do, what this athletic trainer does. But that's kind of, there's no evidence to show one is better than the other. And so we'll watch the video at the end here just for fun. But here's my bougie or not. This is one we used last time, but I'll reiterate. Difficult airways, 96% first pass with bougie versus 82. So you needed a number needed to treat of 7 to get a good airway. That's pretty good. Use a bougie. I don't care if you have that view, stick it in there and get used to it. How to use a bougie? You have to mold it and you have to lube it. So it's pretty pliable. It already has a little hockey puck at the end, but you can still kind of shape it, especially if you're using that King. Is the King Vision a curved blade, or is it more like a Mac?
Curved blade.
So then you kind of have to curve it so that the blade matches.
It has a channel that you push the thing through.
Oh, so you can't really use a bougie. So you already,
Yeah, you can.
you could, I guess, but the channel.
DT tube through there and then.
Right.
Either way, I don't know if you could use a bougie with a King. Yeah, you're right. They have that channel, and you just have to
Get a
push it
channel or
through.
an unchanneled blade.
I wonder if you could still use it. I would just push the tube through if you mess with the airway, or mess with a bougie if you don't have enough room in the mouth. But, so if you can't pass it over the galactic inlet, just rotate it. So if it's kind of hitting it, just kind of rotate it to the side, kind of like an ET tube that's getting stuck. And you can turn it all the way around, and it will usually pop through. You don't always feel the rings as you go through, so if you get hold up about halfway, I didn't bring mine, but there's numbers on it that goes up to 30. If you see numbers, you're probably in, once you get hold up, you're probably you're in the airway. If it starts going down and you're only got like this much out and there's no numbers, you're in the stomach. You can just either leave it in there and try again, or pull it out and try again. Try to keep the blade in the mouth when you're doing this. So you pass the bougie, you keep the blade in there, and then you have your partner or yourself put it on there and just keep hold of the blade in so the tongue doesn't fall down. So you don't just place the bougie, let it go, pull it out, and put this on, and you have to stick the blade back in, just keep it in there. So these things, good things to practice on your standard innovations. Pre-oxygenate first if you can. You can put a nasal cannula on, as well as a bag valve mask with a PEEP valve if we have it, and just blow as much oxygen in there as you possibly can. So that's bougie, and we already went through this stuff last time. Let's watch the video. I don't know if we still have time. We'll skip his introduction. Oh no! What? Let's try this other one. It worked at home. No, I'm just not allowed to go to the internet. Someone.
Get your sections back in the station.
There we go. Where's on his face? Oh, no sound.
Removal, helmet removal, what to do about shoulder pads.
Everything in this scenario, medical personnel on the sideline, you might be able to remove the helmet and shoulder pads during or before transport. All right, in this scenario, we have an athlete who has collapsed. He's laying motionless on the field in the prone position. Obviously, an athletic trainer identifies this as abnormal, immediately responds. First thing he does is stabilizes the head and C-spine and assesses what's going on. Once he identifies there may be a head or a neck injury, he makes the signal to have
Make sure you got the signal.
the other staff immediately help and respond by bringing everything in this scenario, including spine board and airway equipment. Immediately they pull his right arm down in plane with his shoulder pads to get ready to
So
log
this is kind
with
of
him.
a lot of detail, but it does show how to roll
On
somebody
the call
onto a
of the
backward
person
prone.
managing his
I
head
thought
and
it was
neck,
kind of
they
something I don't think about.
roll in unison, keeping spine together. We need a third person. If you have it, if you don't, you can do it with two.
Okay, halfway up on 3.
On the head and neck's call,
1, 2, 3.
log roll.
Slide forward.
If you have the board ready, you can pull the board straight up.
Good.
And using your knees to support the board, we can lower him onto the board
1, 2, 3.
and then ease our way back down. It's very common in this scenario, they're not centered in the board, so it's worth having someone come up at the shoulders and someone at the torso, one arm on either side, like this, and someone at the hips. You've got the hips, I've got the torso. Carrie, why don't you grab the hips? I'll go to the legs. One person shoulder, one person torso, one person hips. On airways call, slide them over
1, 2, 3.
and center them on the board. In this scenario, we have an athlete who's collapsed on the ground. He's laying prone, motionless. Athletic trainer identifies this and immediately responds.
I'll do that again.
Together in unison at the person who's managing the head neck's call.
So all they do here
we
is
lift about
just
6 inches off the ground
roll them over
and hold
and they're
it in
going to stick the
position
board
while someone.
underneath.
Up on 3. 1, 2, 3.
So that's it. I mean, another way to do it is roll them over and then put the board
And
underneath.
down.
Either way is fine.
1.
So that's skinny.
So once the
Yeah, they're
patient
lying
has
back.
been rolled onto their back, and we make the decision that we need to transport with spine board precautions, or if there's an immediate need to get access to the airway, what we need to do is take the face mask off. So in order to do this, most helmets have 4 clips. The way the clip is affixed to the helmet is different for each helmet. Oftentimes it's affixed with a screw, sometimes it has a push button lever, sometimes it has a skinny clip, sometimes it's a very broad clip requiring more than one cut. So you need to be familiar with the different types of helmets that the athletes are wearing. In this scenario, we're going to show you how you would unscrew. The first ones you want to unscrew are the ones on the sides. That way, if you had to, you could roll the face mask up. So you unscrew, and then it becomes loose, and you can slide the face mask up if you had to get quick access to that airway. You can't leave it in this position because if it gets bumped, it acts like a lever arm and can torque the neck. So you need to unscrew or cut the center clips. In this scenario, we'll go ahead and show you how you would cut those. You need to have both a screwdriver or something to cut the clips off with. Oftentimes the screw will start to spin and will not be able to be removed with a screwdriver. If you use a power screwdriver, sometimes the batteries will be out. They do make equipment specifically designed to cut these. This here is the FM extractor, which is a device that is designed to cut helmets, the clips. This, you just make one cut right across the center there and just leave that plastic piece in place and lift it up. Oftentimes, you can use garden shears to do this. They have another one called Trainer's Angels, which just makes a big cut across. What you do is you want to cut the plastic and lift the face mask off. And once this is done, what you start to do is put chalk blocks on either side and strap them to the spine board to get ready to transport to the hospital. If you don't have chalk blocks, you can use towels. If you don't have towels, oftentimes EMS personnel will have, chalk blocks or pads designed for this. Once you have this in place, you'll want to basically either tape or strap the helmet to the spine board. We find it's easier oftentimes just to have tape, since trainers typically have that on their person. You want to tape it in two positions, one across the forehead of the helmet, and then another one going across the, I believe the chins have the,
We're not gonna have any of that shit.
hands and arms in, so to immediate access to the chest or to an airway if someone is unresponsive, not breathing, pulseless. Or in some scenarios, you may have enough qualified personnel on the sideline to take the helmet and shoulder pads off, and NATA has come out with a position statement now stating that if you have qualified personnel on the field, and you have numbers to do this, and you've practiced it, it can be safe to remove the helmet and shoulder pads on the field before transport. Oftentimes they come to the emergency department and ER physicians and staff there are not familiar with how to remove helmet and shoulder pads, and if you remove one, you need to remove both. So in this scenario, if he was pulseless or if I needed to get immediate access to his airway, I would stabilize the head and neck from above. I'm not so worried about his face mask right now. You can cut it off if you want, if you're worried about getting access to the airway, but it's just as easy oftentimes to leave it on if you're going to remove it. What you'll do is you'll cut the jersey straight up the center. And you'll expose the chest plate. What you can do is either cut the axillary straps, or you can unsnap them or unbuckle them.
Cut the jersey from the armpits too.
That's correct. And you'll need to cut the jersey at the armpit here. Then some of the newer equipment have a solid plastic chest plate here. The older equipment has sort of these shoestrings. If it's a solid plate, you can try to cut through it. If you can't cut through it, you may have to slide your hands up underneath to stabilize the head and neck from here at the chest. You put both hands alongside, one on either side of the neck. Your thumbs are along the maxillary area, and your hands in the back are stabilizing the neck as well as the occiput. And you're stabilizing C-spine from the torso. If you can cut through the chest plate, or if it's shoestrings, you can cut alongside here, which makes it easier to get access to the chest. Very quickly, this can be done. Cut the jersey, take off or cut the axillary straps, cut the chest plate, and expose the chest. Right here, I can apply my AED. I can start CPR or compressions, and we can start resuscitating an athlete. From here, I will stabilize the head and neck. You have to either unstrap or cut the chin straps. It's easier to cut it. I don't know if I can cut this one, can I?
Yeah.
And you just cut right through it. Get it out of the way. If you're able to, you can remove the zygoma pads. If you can get them out, you can slide them out. If you can't, just slide your hand on the inside of them. And again, both hands on either side of the neck, thumbs up near the zygoma and maxillary area. And I need to communicate with the person who's managing head and neck right now and say, listen, I'm in position, I've got it on 3, I'm stabilizing head and neck on 3. 1, 2, 3. From above, he applies axial or outward traction on the helmet and slides straight up, keeping inline traction. From here, I'm still managing his head and neck. He basically grabs the shoulder pads and pulls straight up and removes the shoulder pads. From here, we communicate. I relieve my head and neck spine duties to him, and we bring a seat collar in, sliding it up, putting it in place. And from here,
Did all that work, man.
I wish all
very
of our
quickly can
patients
get
Probably
access to the
should've
airway to
sized that
intubate, to
first.
put in LMA, Combi Tube, King Airways, and I can still continue my resuscitation with the AED, CPR, and we can get them off the field into the ambulance, into the ER.
Bravo, bravo.
I know it's a lot of words, but you know, it seemed, I didn't know what I was doing, so. Maybe you guys already had all that knowledge, but I know I didn't, so. Next month, we got trauma people from St. B's coming to talk, so think of questions you wanna ask them. And then, any questions this month, or what's going on? We're gonna be doing a lot of work on protocol through the end of the year, hopefully by January, kind of revising any, so if you have thoughts about a certain protocol or something you want changed, tell Mark or myself.
Yeah, just send me an email if you got any thoughts.
We got, you know, some work to do. Any input from y'all that you see as annoying or want changed, we'll consider anything there.
Anything that's annoying.
Anything that's annoying, that's, needs to be changed
In the protocol.
in the protocol.
Oh.
Oh.
Who's here on their day off? Was it?